Dr. Nicholas Grassley is a professor in the Department for Infectious Disease Epidemiology. He is interested in the individual immune response to vaccination, particularly for enteric infections such as enteroviruses, including poliovirus and rotavirus, and how this translates to impact at the population level. He studied biology at Oxford University, trained in epidemiology at Imperial College London, and learned mathematics with the Open University. He was a Royal Society URF from 2004 to 2011 and then professor at Imperial College London from 2011 till date. He has served on various boards and committees, including the MRC Infections and Immunity Board from 2012 to 16 and the WHO SAGE Polio Group from 2008 to 2020. He teaches on the MSc Epidemiology, MPH and undergraduate biomedical courses at Imperial College London. His work is funded by the MRC, Wellcome Trust, Royal Society, WHO and the Bill and Melinda Gates Foundation.
Good afternoon. Thank you very much for this opportunity to speak at the 5th Medicine Annual Conference at CMC virtually. My name is Nicholas Grassley. I'm based at Imperial College London. And I'm going to talk to you briefly around the role of mathematical models in the response to the COVID-19 pandemic. And in particular, I'm going to focus on the question around vaccine prioritization. So what has been the role of modeling during the COVID pandemic? Well, modeling has been central to many areas of our response in forecasting cases and hospitalizations to help with planning the response and provision of healthcare, to help estimate the extent of transmission of the virus, or the R number, the reproduction number, telling us whether we have the virus under control or not. And for example, predicting the impact of non-pharmaceutical interventions, such as lockdown or school closures, and how those can be optimized. They've also played an important role in vaccine policy deliberations, particularly with respect to the question, who should receive the vaccine first in order to maximize benefits? And that's the question that I'll be addressing in this presentation. Firstly, what do I mean by math modeling? What is math modeling of infectious disease? Well, to me, it's simply the quantitative analysis of infectious disease data, typically with a mathematical representation of the process generating the data. So it goes a bit beyond what we would view traditionally as statistics. And a classic example would be the SIR model of transmission. The model should be as simple as possible, but not simpler, not so simple that it no longer explains the underlying processes. If the model is too complex, we risk replacing a complex and poorly understood world with a complex and poorly understood model. So, in terms of the question, who should receive COVID-19 vaccines first? This is going to be sensitive to some key questions. What are we trying to achieve? Are we trying to minimize deaths? Are we trying to minimize hospitalizations and preserve our health systems? Are we trying to reduce the number of cases, number of infections and the associated morbidity and the possibility of long COVID, so persistent symptoms following infection? Do young lives matter more than older lives, since they have more life ahead of them? And how well do the vaccines work? We will know from the phase 3 clinical trials whether these vaccines prevent COVID, and in fact the first results that have appeared over the last 2 weeks are very encouraging, but we won't know how well the vaccines work in terms of preventing severe COVID disease or mortality. We don't know how well the vaccines will work in preventing infection or transmission either. And we may not have a clear idea of how well the vaccines work in the very elderly who are the most vulnerable to COVID. We also don't know what the timelines for supply might be how much vaccine will we have and when, and what will be the state of the pandemic when we have sufficient vaccine to immunize a significant proportion of our population. And finally, what kind of coverage can we expect when we roll out our vaccination program? Will we be able to deliver an adult vaccination program effectively? And will people be willing to receive the vaccine? Will there be demand for this vaccine for a disease that many view as relatively mild? So mathematical modeling has been key in addressing this question of who should receive COVID-19 vaccines first, taking into account the uncertainty in the answers to these questions. So firstly, what are we trying to achieve? If our aim is to save the most lives, then our calculations are fairly simple. This graph on the left here shows the infection fatality rate as a function of age, shown separately for males and females. These are data from over 15 countries. And what you can see from this graph, which is plotted on a log scale, is that the risk of dying following infection, if you're in 60 years old or over, is more than 100 times higher than that if you were in your 20s. So what that means is a strategy that distributes vaccine to the elderly, to the oldest age groups first, is going to have the biggest impact on mortality. It will save the most lives. And that's shown in the graph on the right here, showing as we increase the total vaccine supply, shown on the x-axis, then the reduction in deaths is steepest if we target the 60-plus age group, as opposed to targeting younger age groups or distributing vaccine irrespective of age, shown by the orange line there. These are calculations from Kate Bubar and Dan Larimore in the US for India, based on Indian demographics and mixing patterns. And all the data that I'm going to be showing you today is not my own work, but the work of others that we've been reviewing as part of the WHO SAGE working group on COVID vaccination. We also need to protect the vulnerable at all ages. We know that a number of health conditions put people at risk of severe COVID following infection. Whilst many of these comorbidities, such as diabetes, obesity, heart disease, cancer, increase with age, there are younger adults who suffer from these conditions and are at risk of more severe outcomes following infection with SARS-CoV-2. So the graph on the left here is data from the UK, which shows the number of people in the UK by age, with healthy people shown in purple, and in red those with comorbidities, so that put them at risk of severe outcomes. And this is an aggregate across a list of comorbidities identified by WHO as increasing risk of severe outcomes. Now you can see that the prevalence of those comorbidities does rise with age. However, there's a significant prevalence even in the younger age groups. So on the right here is results of some mathematical modelling done at the University of Warwick, looking at the decrease in deaths with an increase in vaccination coverage, targeting different groups in succession. And in this case, it's showing the optimal strategy modelled for the UK for a vaccine with a range of efficacies from 50 to 90%, and a vaccine, in this case, which protects both against infection and disease. And you can see that the optimal strategy in this case involves targeting those in the 80-plus age group first, followed by those with comorbidities, irrespective of age, followed by those in the 60-plus age group. So those individuals who are vulnerable need to be protected by vaccination, irrespective of their age. What if our aim was not to save the most lives, but to save the most life years? In other words, if we put greater value on younger lives. On the left here I've plotted a chart of expected years of life remaining as a function of age for women in the UK. So you can see from this graph, saving a 20-year-old's life saves around 5 times more life years than saving the life of someone in their 80s. However, because of the very steep rise in the infection fatality rate with age, even a strategy where we value younger lives more greatly, so we aim to minimize the numbers of years of life lost to COVID, we would still target the older age groups and those with comorbidities first. And that's shown in the graph on the right here. What about if we wanted to prevent the most cases or infections rather than preventing mortality? Well, the graph on the left here is the one I showed you earlier, showing the reduction in mortality or number of deaths as we increase vaccine supply. And you can see that the optimal strategy, the one that results in the steepest reduction in deaths, is the one that targets those who are 60 years and over. However, if we want to maximize the reduction in the number of infections, shown in the graph on the right there, you can see there's not really a big difference between strategies that target specific age groups or those that distribute vaccine irrespective of age. In fact, there's a slight benefit in targeting the 20 to 49-year-old age group, which are the group most responsible for transmission of the virus. So if we really wanted to reduce infection and cases rather than mortality or years of life lost to COVID, we may think about distributing vaccine first to younger age groups. What about the possibility of reducing infections to such a low level that we manage to eliminate COVID-19? This graph illustrates the number of deaths prevented per 1,000 immunized as coverage increases for vaccines with different efficacy and are shown as a function of the mode of action of the vaccine. If the vaccine prevents disease only, but doesn't prevent infection and shedding of the virus, such that even vaccinated individuals can contribute to transmission, then shown with the dashed lines here, then as we scale up coverage, we just see a linear increase in the numbers of deaths averted, and we will never eliminate infection with vaccine alone. The solid lines, however, show the number of deaths averted for a vaccine that prevents infection and therefore onwards transmission of the virus, as well as preventing disease. And there we can see a much steeper increase in the number of deaths prevented as vaccine coverage increases. And indeed, at a certain coverage level, we no longer see any benefits because infection has been eliminated. Now, the recent trials suggest that the efficacy of COVID vaccine is over 90%, at least in the short term. That's vaccine efficacy against COVID-19 disease. It's likely that efficacy against infection and shedding of the virus in the throat and upper respiratory tract, and therefore onward transmission, is less. And so we still don't know the efficacy number for vaccine protection against infection. However, it is possible, with the encouraging results that we've seen so far for the vaccines, both in human trials and in preventing infection in animal models, that elimination of COVID, at least locally, may be achievable with reasonable levels of vaccination coverage. So these are some examples of the modelling work that's being done to inform the WHO SAGE COVID-19 vaccine recommendations. In October, a roadmap was released by WHO for prioritization of the vaccine, and this roadmap has been informed by these kind of models. just illustrated one of the scenarios for how vaccine would be allocated on the right of this slide. Of course, not all questions can be answered by modelling. Some of the questions, some of the priority groups, for example, essential workers, we may not need a model to justify prioritising those groups for receipt of vaccine. In the coming weeks, WHO SAGE will provide interim guidance to countries on COVID-19 vaccine use, following the emergency use authorization by a regulatory authority. And those guidelines will also be informed by the kind of modelling work that I've presented here. Of course, that's not to say that these recommendations are set in stone. These recommendations may evolve as we learn more about COVID-19 epidemiology and about the efficacy of the vaccines. Thank you very much for listening, and I look forward to the question and answer session later today. Thank you.